to have Dr. Swapnel Shaw with us today, who's going to be talking about orthopedics and primary care. And I'm going to let him kind of take over from here, introduce himself, and get right into the CME. So, welcome, Dr. Shaw,
Great.
and thank you for your time this lunch
No,
hour.
no, thank you guys. I really, really appreciate the lunchtime. I know that it's valuable for all providers, and I'm just really honored to be able to speak with you guys. That we've known Dr. Miller for a very, very long time. Um, Dr. Crozen was going to join me, but unfortunately, he got called into a polytrauma over here at Eden, so I'm going to do his part. But we're going to talk about some basic orthopedics for primary care. So let's get started. Um, let me get, there we go. So these are just our disclosures. We do present and consult for Johnson and Johnson, and we do these lectures for them as well, and another company named OrthoDev. None of these relationships that influence this content of this activity. And this is going to be 1 credit for CME, which I'm sure you guys are aware of already. Here's just a way to put the names to the faces and vice versa. That's me on the left there, and that's Dr. Crozen on the right. We have been a long-standing members of the East Bay community. We did residency here in 2004 at Highland, and then did trauma fellowships and came back to work at Highland, and have worked there since 2010. Just recently, we also expanded to our private practice, which is called East Bay Orthopedic Trauma and Reconstruction. And the reason we did this is because we had a lot of patients who we wanted to take better care of. We wanted better parking, we wanted better access, just more control over the care we give. So we have kind of reopened here over in Castro Valley in our office. We definitely take CHCN patients and Alameda Alliance patients, and we are excited to keep serving the community in kind of a more refined way, that's still going to be high level, but a little more personalized for all of our patients. And so we're excited. Our learning objectives in this hour are going to be to increase our knowledge of shoulder, knee, and hip arthritis and other chronic conditions of the shoulder. We're going to increase our knowledge of acute injuries of the shoulder, hip, and knee, but also more of the chronic issues that you guys are going to be dealing with as providers. And then how do we say, okay, let's treat these in the primary care setting versus saying, you know what, we've gone as far as we can here, let's get them to an orthopod. So we're going to start with the shoulder because I think that's kind of the trickiest black box that we have in orthopedics. And it really does come down to the anatomy in my mind. On the left side here, you see the anterior view of the shoulder. We see the subscap, which is the internal rotator. And we have over here the attachment of the external rotators. But more importantly, we'll see we have the rotator cuff muscles here coming into the tendon attachment, really separating the subacromial space from the glenohumeral space. And that subacromial space is where I focus most of my work on in the clinic. Over here, we see the backside view. And the backside view is important because that's generally where I tend to inject the subacromial space. The actual the external rotator muscles here of the rotator cuffs all come in from the backside more here, whereas the internal rotator is the subscap. We see here the supraspinatus, infraspinatus, and teres, and these guys are very, very common culprits in pain generation. So the types of pathology are numerous in the shoulder, and I'm sure all of you have seen all of these names and dealt with all of these diseases, but we're going to focus on just a few today to kind of group them together and get you guys to generally be aware of the things I think are the most common things I see in my practice, and kind of over the last 10 years, what I've seen. And I think it all starts with the history. Is we can really delineate a lot and narrow things down with a good history. How did it happen? What happened exactly? Where, when, Why? All of those things are really, really important with shoulder. Is it a dull ache that started a long time ago and just became steadily worse over the last few months to years? Or is it a sharp stab that occurred after a fall? Or is it something that got really bad after a busy weekend cleaning the garage or something like that? So really, really getting a good idea of the history is very, very critical. The radiation of pain from the neck down to the fingers is also important because these things can be very, very confusing to treat. Can it be a radiculopathy? Can it be something else that is nerve related that's causing these confounding factors? The risk factors, diabetes is a big one with adhesive capsulitis and shoulder stiffness in general. Smoking, obesity, what are your job requirements? Does it wake you from sleep? And through my years of experience, as well as actually having these shoulder problems myself, I really realized that the sleep is a big issue for our patients, and it can cause a lot of anxiety to have this pain that gets worse during night, that patients get so scared about nighttime coming. How do we help these people really alleviate their pain and feel better and get rid of some of these pain generators? The physical exam obviously comes next, and the physical exam will be guided by your history. Once you kind of narrow things down, am I dealing with a chronic issue versus an acute issue? You can start narrowing down your physical exam. Otherwise, you can get bogged down in forever with a shoulder exam. So a quick inspection from both front and back. I have gentlemen take off their shirts, and females be in a bra or in a gown, whatever everybody feels comfortable with. I make sure I see the back side and the front side, the posterior and the anterior, to make sure I'm not missing any imbalances. The neck exam is very important, C5 through T1, a quick motor exam and a quick range of motion to make sure we're not missing anything. Palpation is generally kind of difficult to say, hey, here's a specific issue. Most people will just complain of generalized shoulder pain, but I still do it just to make sure I'm not missing something obvious. And then range of motion, active, which is what the patient can do for themselves, and passive is what we can do for them. Flexion, which is just right in front of them, abduction, and internal and external rotation are the main range of motions that I want to know about when I'm examining a patient. Really are guided by the history. For most of our patients, that's going to be a chronic pain, rotator cuff related, and we're going to get into those right now. This slideshow, I'm pretty sure you guys will have available to you, but these are the 5 that I really do every time to make sure I don't mix it up too much. And if 3 out of these 5 are positive, I'm injecting the patient. I'm going to give them a subacromial injection because that means they have some sort of rotator cuff tendinopathy. So let's go through these real quick. The Hawkins exam. You get right in front, get that arm right in front at 90 degrees of abduction and flexion as well, and go ahead and internally rotate that patient. If that's painful and that recreates the pain they have, that's a positive test. The near sign, they pronate their arm so their thumb is down, and you raise up their arm straight in the air. And if that regenerates the pain, that's also positive. The empty can, you ask them to pretend like they're emptying out an empty can, and you go ahead and have them go ahead and resist against your downward motion. If that is positive, painful, that's also positive there. The drop arm sign is more specific for a rotator cuff tear versus a tendinopathy. And what we do is we have them bring up the arm to 90 degrees abduction. You have them slowly lower it. And if they can't continually slowly lower the arm and it just drops at that last 45 degrees, that's positive for a rotator cuff tear versus just a tendinopathy. And then internal and external rotation, basically making sure the arms are down by the side, elbows are down by their side, and you do resisted internal and external rotation. always make sure you watch them walk and make sure you see them from both front and back to make sure you don't see any clear deformities or any massive limps. Imaging, we get first and foremost standing, and it's very important they get standing, weight bearing, bilateral films of the knee for arthritis. If there is arthritis, there's no need to get an MRI unless you have an acute injury with a negative x ray or you have a negative standing film and still have these meniscal symptoms. We see here on the left a good x-ray and on the right a bad x-ray. And many of us have seen these, but it's just nice to kind of see a normal and an abnormal. When to inject, what to inject. I inject rather freely in the knee and the shoulder in the clinic because the downside is low. I've also gotten a knee injection in my knee and it's helped a lot. It helps calm down the inflammation in the knee and it really does treat all kinds of issues from a chronic standpoint. Um, I don't really inject the PEZ right off the bat. I inject the joint itself, and any level of arthritis, whether it involves a chronic meniscus tear or not, is usually pretty safe, and we don't usually worry about anticoagulation. When we don't inject is when we suspect more of an acute injury or any infection. Also, if there's an arthroplasty already there, a joint replacement already there, better to not inject, better to send to us. Sorry there. So, how do we inject? Many people will inject in the flex position, but actually, in medical school, probably about 20 years ago, I learned that the research shows actually the best way to get into a knee is with the patient laying down completely relaxed in the supine position, extended knee, and right under that patella. You have tons of room under that patella. It doesn't have to be right where that star is, it can be even north of that. And as long as you can mobilize that patella towards you, you can get into that knee just parallel to the ground. You can draw fluid out if you need to and inject at the same time. And I usually do some sort of a combination of Kenalog and Marcaine combination there, usually about 1 to 2 cc's of Kenalog and about 4 to 6 cc's of Marcaine. Some people go more, some people go less, whatever you feel comfortable with. The referral. When do we need referrals to orthopods and when can we kind of take care of things on our own? I would say that once you've injected the patient about 3 times over a year period, doing it every 3 to 4 months at a time. We don't want to inject more often than that. And we've done canes, we've done NSAIDs, they're just not getting better. And you suspect some sort of a chronic issue that's not going to get better. Bracing's not working, canes aren't working. They're now only walking 1 block, or they're only being able to walk from their bed to the bathroom. You're seeing a notable change in their lifestyle. Please refer them to us at any point in that continuum. But I would say that up until that point, we're really treating them conservatively.
Okay. All right. And I think there were like some labs that she needed to get done too. So I'll let them know that we'll just start fresh for everything in February. Okay. Okay. I will definitely communicate that, Horizon. Thank you so much for being able to give me a call back. I'm so sorry I didn't want to like bombard you, but I know like we also had a lot of appointments and things that were already set up for your mom. Hmm. Okay. Yes. Okay. Absolutely. So I will once I let them know, and we'll figure out what days the next appointments will be. I'll let you know. I'll give this phone number a call, and we can like kind of talk about.
All right. Are we back here? Okay. Let me share my screen again. All right, there we go. Okay. Let's see. Can you guys all hear me? Can somebody give me a thumbs up?
Yes, Dr. Shaw. And there were also two questions that were asked too. I don't know if you'd like me to hold on to questions or.
Let's go for it. Let's go for it. I feel like I'm just doing all the talking, so I'd love to get some questions in.
Great. I'm gonna read them unless somebody else wants to step in. But for now, one question is: do you recommend checking blood glucose for patients with DM prior to injections?
So I actually don't. What I tell them is I ask them about their diabetic control, and I tell them, um, especially for knee injections, more often than shoulder. But what I tell them is, guys, make sure you're keeping an extra tight eye on your glucose levels in and around the injection time for about 24 to 48 hours, because sometimes you can get very high and elevated glucose levels. And really, all I tell them to do is just keep an eye on it rather than there's no real number that prevents me from doing it at that time. Hopefully that answers the question.
And the second question is, what do you mean by chronic on this slide? And let's see, it could have been the slide before.
Is this the slide here?
And that would be Barbara Bensby who would ask that question.
Mm-hmm. So I believe if it is this slide, then what I mean is referral for chronic issues, meaning, arthritis, chronic pain that has not been resolved in the clinic setting, in the primary care setting, things that may end up needing some sort of a knee replacement versus an acute injury like a meniscal tear, an ACL, a patellar tendon injury, something more acute. Hopefully that answers that question.
If there's any other questions, you can type them in or unmute yourself and Dr. Shaw could answer, or you can get back to you.
Hi, that slide that was just up, I just don't really understand what that slide means.
Are you talking about this
like chronic,
referral?
like absolute A1C control, IBDU? Are you saying that some of these people, if they're using IV drugs or their A1C is 12, you don't want to see them, and we have to make sure that's taken care of before they could get orthopedic help? Are you rejecting them unless we magically control those things?
No. I think these people, these are more indications for surgery. I think we would certainly be happy to work with you with these patients.
Just want a brief hold. Sorry, just one second.
Oh, I'm sorry. Can you guys hear me? Yeah. So what I mean is, if you do send them to us and they need some sort of a surgical treatment, then what we would probably do is, if they have one of these A1C control issues or IV drug use or uncontrolled obesity, we will work back and forth with you until we get them to that level of actually being able to get surgery. And these are kind of absolute contraindications to actually surgery, but that doesn't mean we won't see them. No, we'll see all of them. And I really enjoy working with the primary care because that creates a good buy-in on both ends to make sure that patient's going to get the best outcome possible. Hopefully that, Barbara, that answers your question. Any more questions? Okay. I'm going to keep going here. And we talked a little bit about other non-operative and conservative treatments here, but for patellofemoral disease and for tendonitis issues, I think braces and PT work really well. For arthritis, they can work. They certainly don't hurt, but they're kind of 50-50. I would tell patients to get a brace that makes them feel comfortable over at Walgreens, or if you guys provide them, I think that works. But I wouldn't say that, it's going to solve all their issues. It's definitely worth trying. And then telling these patients that before they come to us, knee problems are an issue, and total knee replacements aren't a button that we push and everything gets better. There are some mixed data on total knees, and really getting to the optimal spot from a primary care standpoint, making sure nutrition's good, making sure habits like smoking have been eliminated, that will give us the best outcomes. And really, like we said, that partnership between the primary care and the orthopedic surgeon and the patient, that triad there, I think is going to be a key there. Let's talk a little bit about hip. Hip is one of my favorite things to do because besides the subacromial injection, hip arthritis is very treatable, it's very detectable, and the outcomes for these surgeries and for these treatments really do change people's lives for the better. I'm a big firm believer in injections in the hip, the knee, the shoulder. But when it comes to surgery, I really, really love hip replacements a lot more than knee replacements. They really are more reliable, and I've seen really good outcomes from them. So we see the anatomy here. We see its basic anatomy, but really the reason I put this on here is to remind us that hip pain is really, really, really important to delineate in terms of location. Groin pain is more joint related. So anterior groin pain is really what I look for versus kind of this side hip and back pain, because we always have to remember that low back pain and radiculopathy can mask as what we think is hip pain. So getting the history as to where it hurts and why is really important. So the causes of hip arthritis, there's a whole variety of them. Mostly it's primary osteoarthritis, which we don't know, it's idiopathic. But hip dysplasia, undetected as a child, often goes on to actual hip arthritis. And then rheumatoid and avascular necrosis is also very, very common in our population, with alcohol use, HIV, as well as prior steroid use for any reason at all. Here we say it's long thought to be kind of wear and tear, but we don't necessarily always know why it happens. And it does affect a decent amount of our population. So hip dysplasia, we'll see more of a shallow cup, and then that you'll see kind of the escaping hip. And the left hip, for some reason, is a little more common there, more common in women, and it does lead to early arthritis. It can be treated conservatively with leg length discrepancies being treated by shoe wear with heel lifts and canes, always in the opposite leg, versus the knee, which we do canes in the ipsilateral leg. Rheumatoid arthritis, obviously, you guys all see that. And eventually, they end up needing some sort of replacement just because the mechanics fail them. But the medical treatment has certainly decreased our need to operate on these patients as much as we used to. Avascular necrosis, I see this quite a lot, as well as post-traumatic arthritis due to avascular necrosis from femoral neck fractures and such. So once the femoral head loses its blood supply, it's extremely sensitive. It collapses. You see more femoral sided changes than you do on the acetabular side here. And that's when you can get avascular necrosis, arthritis, and then eventually need some sort of a hip replacement. Non-operative treatment, physical therapy does reduce stiffness, but it doesn't necessarily always work as well as it does in the shoulder. If the patient is having grinding arthritis in the hip, it is just hard for them to move sometimes. And so we try it for earlier levels of arthritis, but once it gets moderate to severe, it's very difficult. Cortisone injections, I'm a firm believer, not only in treating the disease, but also diagnosing it, especially in somebody who's got mild to moderate and we can't necessarily tell where it's coming from. Referring for in cortisone injections, ultrasound guided is really the gold standard now. And that is helping us delineate after the injection, hey, did the patient get better? Did their pain go away? Or is it kind of more coming from the back, the side of the hip, and the actual joint injection didn't help, then we know we might be barking up the wrong tree. And we talked about walking canes to use in the opposite hand as well. So I'm not sure if you guys have a good referral base to send for injections, but this is also something that we'd love to help out with. I'd love to answer some more questions now. We'd love to see any of your patients. And these are our private cell phone numbers, our office number, our emails. But I'd love to actually just have a discussion now, kind of like we started, to answer some of your questions to see what your major concerns are with some of these topics.
Dr. Shaw, there's also a few questions in the chat box as well. Would you like me to read them, or can you easily access
Yeah,
them?
let me see if I can get there. Sorry, I don't see that.
I know it can be really complicated.
The chat box, I go
Here.
to more. Is that where? Chat, there it is. Okay, got
No,
it.
how
I
about
got
I
it
just-
here. Here we
Yeah,
go.
you got
Yep.
it?
Mhm.
Cool.
Okay.
Yeah.
Okay, so I'm gonna start. I'm just gonna start at the top. Let's see. So, best type of braces for osteoarthritis versus meniscus or other issues. So, like I said, you know, arthritis, really what I do for arthritis and even meniscal tears is I start very basic at Walgreens or at CVS, and I just have people try to get those hinged knee braces that are soft and have an opening in the patella. And those are usually about $20 to $30. We don't carry them in the office because they're more readily available there, and patients like to try on different ones. So I start with those, and then very rarely will I go above that in terms of the level of bracing, because at that point, usually they need some more significant treatment. The next question here is which hand and which condition for the cane? And that's a great question. Remember, the weakness in the hip causes you to actually lean on the opposite side more and really causes what we call a Trendelenburg gait. So what I remind people is for hip disease, we have the cane in the opposite hand. And for knee disease, we have it on the same side. So hopefully that answers that question. But yeah, that's a great one. Can the radiologist give us the diagnosis with the X-ray hip for those conditions that you mentioned? I believe so. Sometimes you can notice, obviously, rheumatoid arthritis will be diagnosed in different ways than just X-rays, but they can help you. Like I said, with more femoral head-sided disease, you're going to have more of an avascular necrosis picture. When you have dysplasia, where you have an escaping hip and a shallow cup, that's going to be more dysplasia. And then when you have kind of more balanced disease on both sides, and you have that spurring in the osteoarthritic picture that you'll have in the knee, that's going to be more osteoarthritis. And when do we recommend MRI? I recommend MRI when in two conditions. When you're certain the pain is coming from the hip and it's in the groin, and you can't see it on X-ray. So it might be either a femoral neck stress fracture, which normally occurs in young, active patients who are sometimes overly athletic and won't slow down, or even on patients who have been on bisphosphonates for a long time. So those two populations. And if they're having pain when walking, but you can't see anything on X-ray, but you really do feel suspicious, I would make them non-weight bearing, give them crutches, and get an MRI. The other thing is if they feel a clicking after an acute injury, that might be a labral tear, so I would recommend an MRI there. Let's see here. The phone number has disappeared, but overall, I'm not overly aggressive on MRI with hip. And I think those are all the questions. Ms. Barbara wanted the photo of the phone numbers up there. Let me get that for you. And there they are. And hopefully this talk will be recorded too. But I really, really appreciate the relationship we've had with CHCN for all these years. I really hope that we can give you guys continued service and more specialized service with better patient satisfaction, less of some of the headaches that we have with the Alameda Health Systems stuff. Now, we still see patients at Alameda Health System. We still have clinic there every week, and we are not leaving that community by any means. It's just this private office gives us a little bit more of their questions at all.
There are a few more questions that arrived in the chat box.
Oh, good. Okay, let me go through them.
Keep the questions coming, everybody.
Please
and
do.
Also,
Thank you so
you'll be
much.
receiving an evaluation link. So in order to get your CME certificates, you'll need to complete the evaluation that I'm sending in. It'll take less than 2 minutes.
So I see here it says, do you typically order an MRI for patellofemoral pain, or is it more of a clinical diagnosis? Great question. I think that came from Alicia Chen. So that is definitely more of a clinical diagnosis. And so patellofemoral pain will be kind of vague anterior pain that's worst going down or upstairs, usually downstairs. And it usually has to do with a weakened quad muscle, usually the vastus medialis, actually. And that will normally be a more of a history and an exam with a negative x-ray. If I see that the quads are weak on that side, I'll order x-rays. I'll make sure they get 6 weeks of good quad strengthening exams and quad strengthening exercises. And if they don't get better at the 6-week mark after good steady therapy, and I mean dedicated therapy, 3 times a week for 6 weeks, going to see the therapist and doing the exercises every day. If I don't see an issue with improvement there, and I can continue to see pain, I may order a patellofemoral brace, and also then get an MRI and send to an orthopedist. Do we accept Medi-Cal? So Medi-Cal, we don't take in the private office, but that's why we still see patients over at Highland to make sure everybody still has access to us and the care we provide. So hopefully every one of your patients that needs to get seen will get seen in a timely fashion. And I believe that is all the questions. I could be wrong. Jen, if there's any more, I'd love to take them. Okay, so that's I think Tanya Brown. Basic review of the shoulder exam for chronic shoulder pain. Sure, and I can quickly review that. I'm gonna go to that thing because it is a little tricky to remember. But hopefully, Jen, are they gonna get these slides too? Hopefully you guys will get these slides.
Yes, so you'll receive the slides and hopefully the recording. There is some in the next couple of weeks after we get everything together with the evaluations and CME certificates, but you will receive these slides.
Great.
Yes.
Okay, I'll just do a quick 2-minute review then for Tanya. Just to kind of quickly gloss over it here. History is everything, Tanya, and you'll see that in the recording that you watch. But the main things I do is I make sure that I check for range of motion and flexion, abduction, internal and external rotations are the main ranges. Active versus passive. What can the patient do, which is active, versus what can I do for them? Okay. Now, if I'm suspecting more of a chronic issue, like rotator cuff issues or tendinopathy, then I'm going to be guided by that history to go in the route that I'm going to show you right now. Okay. And what I look for are impingement signs. The memorable maneuvers slide here is what I'm talking about. Okay. These 5 things, if 3 of these are positive, or even less, sometimes just 2 to 3 are positive, I will then inject the patient with a subacromial injection to diagnose them and complete my test. So a Hawkins exam, once again, patient goes up to 90 abduction right in front of them. I internally rotate them myself. If it recreates those pain generators that they're having and feels familiar to them in terms of a negative way, that's going to be a positive Hawkins sign. The near sign, I pronate the thumb down and I raise up the hand all the way up. If it hurts during any range of that motion and recreates that pain, that's positive. That's the near sign. The Job, the empty can, I ask them to pretend that they're emptying out a can, and I push down and I have them resist me. If that hurts, that's also positive. And those three are the ones for supraspinatus. The drop arm is for a rotator cuff tear versus just tendinopathy. I go ahead and elevate the arm up to 90 degrees, have them themselves lower the arm slowly from abduction down to the side. If they suddenly drop the arm at about that 45 degree, they can't hold it up in a nice steady fashion, that is a positive drop arm sign, and I'm ordering an MRI and doing an injection most likely. Internal and external rotation signs, really the internal is for subscap. And so I will have their elbows at the side, push in against my hands against resistance. If I notice one side is specifically weak or generating a lot more pain, that's going to be a subscap sign, positive. And external, it's going to be more for teres minor and infraspinatus. And then, we talked a little bit about that and what that means. I would go ahead and inject anybody that has 2 or 3 of those signs, impingement signs, and I would go ahead and inject them. Now, somebody said, should I go ahead and do an injection for a drop arm sign when concerned about a rotator cuff tear? Absolutely. I have no problem injecting within a rotator cuff tear. Rotator cuff tears will present in all different ways. They'll either be functional and have just pain, or they won't even be able to raise their arms. But the injection itself will, at worst, bathe that area and get them to do physical therapy. And not every rotator cuff tear has to be actually operated on. You can get better with just PT and live with that. So yes, I would go ahead and do the injection. Now, if there's a positive drop arm sign, I might have a lower threshold to order an MRI because I'm also suspicious of a tear rather than just tendinopathy. Whereas just for tendinopathy, I would let them do the therapy. I would go ahead and inject them and then see them in 6 weeks and make sure that they're better. If they're not better at that point, I would order the MRI. Hopefully that makes sense for Emily Newhouse there. I think Stephanie wanted to know, for the empty can sign, where am I applying the force? When they rotate their arm or after? So for the empty can, really what we're doing, they're not really, yeah, they're rotating first and then say, okay, please resist my downward force. And then I go ahead and apply the force. So they're already like any other questions here? And like I said, I'm going to go to the last slide here and give you guys again a picture of how to get to us. Our website is eastbayortho.net. There are our personal cell numbers, our office number, and our personal emails as well. We really want to be super accessible to all of you. So even if you just have questions about patients before you refer them, or just general ortho questions, please feel free to call us, text us, email us, whatever. We're super available, and we really value the relationship we have with all of you guys.
Any last minute questions, everybody? There were a couple of shout outs to you, Dr. Shaw, for this being so helpful and relevant. So thank you for that.
No, this was an honor, and we'll reach out to you guys again and maybe give another talk. If there's certain topics you want to learn more about during these lunchtime things, please holler at us, and we can prepare talks, and hopefully we'll get to meet in person one day soon after everybody gets vaccinated.
Actually, that'd be great. If anyone has any ideas for talks, why don't you put them into the chat box to kind of give Dr. Shaw a sense of some other content or information that'd be helpful for you in your practice.
Yeah, and Dr. Crozen was really, really sorry he couldn't be here, but he and I are definitely committed to the relationship we have with you guys. Thank you guys all. And I don't see anybody. Yeah, back pain eval. Oh, always our favorite, huh? Back pain. I think that would be good because we're very I'm very basic when it comes to back pain. I actually don't think that Western medicine does a great job treating back pain, and so I would love to give my perspective on back pain, and and I'm sure Dr. Crozen has his as well. But something kind of more specific and helpful for you would be good, and we'll keep that in mind maybe for the next talk. Um, I got one request here. Oh, there you go, Jana. Okay, perfect. I just wanted to make sure you could email everybody the talk. Awesome.
Thank you so much, Dr. Shaw. We really appreciate it. If anyone, Dr. Shaw, if you have 7 more minutes till 1 p.m. Oh, it looks like Alicia Chen is saying IT band for hip pain, maybe in the future too.
Yeah.
Sounds like that all goes with the back
Yeah,
pain
yeah,
too,
for
right?
sure. And I think, it's those are tricky. Those get more specific. And I actually tend to do and we can definitely, give more talks about it later. But Alicia, I actually do we tend to inject those. Um and when we do trigger point injections, we don't use Kenalog. We use Celestone because, like for example, carpal tunnel injections, troch burst injections, those all get Celestone because those are water soluble and don't cause skin or fat necrosis on that level and discoloration in that area. Whereas intraarticularly, it doesn't matter if you have fat soluble or water soluble. Usually on the skin, we'll just use water soluble, and then I'll send them to therapy and 6 weeks, if they're not better, MRI to see if there's some sort of a tendinosis or tendonitis there. But yeah, definitely that sounds like maybe we can do something like that in the future as well.
Thank you, Dr. Shaw. Dr. Shaw, if you have till 1 p.m., perhaps maybe you could just hang on for a moment if anyone wants to stay and ask you any questions. That could be really
Absolutely,
useful.
yeah. No, I'm right
Cool.
here.
Great. And there you go. You had another question from Kyle Walsh.
For TFL pain, yeah, you totally can. Um, I'll inject almost anything. It's pretty funny, but I really do believe in injections. And the only reason I'm so adamant about it is because I've been in practice now long enough where I've actually had every single one of these problems and become a lot more empathetic towards these patients, um, rather than just, when you're a resident and you're treating them, everything is kind of out of a book. But I've actually suffered from a lot of these myself, and the injections help because they give you a little boost. TFL is tensor fascia lata, and it's kind of just that side of that thigh going all the way down into the knee, that TFL pain. And I inject where it hurts, send them to therapy, give them NSAIDs, and I usually use meloxicam. I hope you guys have started using meloxicam more. It's been really a miracle worker for us, and I feel like doing that injection just gives you that little boost and gets you focused on the therapy and the rest that you need, on the other things. Maybe you just need to stop working as hard and focus on your injury, or you need to stop playing whatever sport it is, or whatever the activity is. If it can be modified, you should. I recommend NSAIDs right off the bat. Right as soon as I note some sort of a chronic inflammation or even acute inflammation, I use NSAIDs right away. The question is, if it will take weeks to get PT appointments, as is the case with us, how would you modify your treatment plans? So I will also email you guys out on our American orthopedic website. There is a great shoulder regimen that you can print out for patients that they can do on their own with just TheraBand and exercise. And that's actually what I used with my shoulder, and I did not It's a whoops, os.org, and you just type in shoulder rehab. And that is a great way to get people started with physical therapy before they actually get called by the therapist. Do I feel meloxicam is just as effective as ibuprofen at high doses for reducing inflammation? I think it is, but everybody is different. I think that for me, at certain times, right after an acute inflammatory process, I will need the ibuprofen right after I have some sort of an acute activity, an increase in activity that'll cause me a little bump in my inflammation. But for chronic inflammation, that comes and goes, I still think meloxicam does a pretty decent job, and hopefully reduces the amount of pills people are taking every day. 83-year-old with a right rotator cuff tear on MRI. Is surgery the only option? And thankfully, no, it's not the only option. It depends on how bad that rotator cuff tear is affecting that person's life. Are they having chronic pain? Are they starting to have an escape of that humeral head outside of that joint? And if they are, and if they can't get, if it's a massive rotator cuff tear, they may actually need what we call reverse shoulder arthroplasty instead of actual rotator cuff repair. But they may not need anything at all. They may just need an injection and therapy and be able to live with what they have. So it's really interesting to see how many people can live with tears and not have to actually undergo surgery.
Thank you, Dr. Shah. I wanted to ask what you meant by humoral escape. Like, what do you have to do on exam?
Yeah, so you don't have to necessarily do anything. If you look here, what I mean is that when they have massive amounts of rotator cuff damage, sometimes they'll get rotator cuff arthropathy here. And you can see here on the left, the humeral head is sitting where it needs to. But if you remember the anatomy, the rotator cuff keeps the head in place and prevents it from escaping to the north here. And you can see here, you have a massive rotator cuff tear, which is causing the humerus to not be in its place. It's riding high and now getting arthritis. So this kind of a picture is kind of a severe tear, irreparable tear combination with arthritis. This is what happens if you let a symptomatic rotator cuff go for many, many months, many years, and you don't do anything about it. This can happen. So really the patient who has a massive tear, who is doing well, you still want to see them every 6 months to a year to make sure they're not getting significantly worse, even if they don't want surgery.
Okay, thank you.
Yeah. Meloxicam 15 milligrams daily. Yes, so I don't add the ibuprofen to it for the meloxicam. I'm either doing one or the other. So usually for these chronic issues, I'm doing meloxicam. Any other questions? So it's 1 o'clock. I'm going to get going. I got clinic now, but please feel free to reach out to us at any time. Our office is open, and our numbers and our cell phones and our emails are open, and please never hesitate to reach out to any of us. I really appreciate your guys' time, and thank you so much.